Good afternoon and welcome to today's IAC webinar, Building Blocks of Strain Imaging, Part 2. My name is Kelly Baer and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation, and we'll try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASE CEU credit, you must be registered, logged into this webinar, then complete the survey. The survey will open at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you're viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC, ASE, and SDMS. And now I would like to introduce today's guest presenters. With us today are Dr. Juan Carlos Plana and Pamela Burgess. Dr. Plana is the Chief of Cardiology at Texas Heart Institute, Baylor St. Luke's Medical Center in Houston, Texas, where he is also Director of the Cardio-Oncology Center and Co-Director of the Center for Advanced Cardiac Imaging. Dr. Plana is board certified in cardiology and echocardiography. His clinical and research interests include cardio-oncology, valvular heart disease, diseases of the aorta, and advanced cardiac imaging. Pamela Burgess is the clinical manager of the Cardiac Ultrasound and Stress Testing Lab at Wake Forest University Baptist Medical Center in Winston-Salem, North Carolina. She serves on the IAC Echocardiography Board of Directors representing SDMS, is an IAC application reviewer, and brings over 25 years' experience as a sonographer. Both are true experts in the field. And with that, I will now turn the webinar over to Dr. Plana. Doctor?
All right. Well, thank you so much for the kind introduction. So, as you know, this is the second of 2 talks that I have given. The first one was kind of going over the basics of a strain, and this time around, we are going to dedicate the next few minutes to talk about its application in cardio-oncology. And really what I want to do is I want to do it using the scaffolding of the expert consensus that I had the honor of chairing. I don't have any disclosures to make, and as I mentioned, we published this document in the fall of 2014, and this was the result of an enormous collaboration between 2 societies, the American Society of Echo and the European Association of Cardiovascular Imaging. The document is organized in 5 parts, and what I want to do in the next few minutes is to really outline the messages that you need to remember from this consensus, the messages that you need to take home today. So without any further ado, let's go ahead and get started. The first part of the document addresses a very important issue, and that is the fact of how is that we are gonna, what definitions we're gonna use. Historically, we use the term cardiotoxicity, and the problem is that although we meant it, to discuss left ventricular dysfunction in the setting of administration of chemotherapeutic agents, if we are strict, cardiotoxicity can mean a lot of things. When we administer these chemotherapeutic agents, they can do a lot of things to the heart of our patients. They can cause pericardial effusions, they can cause LV dysfunction, they can cause coronary spasm, and as you imagine, to use cardiotoxicity to really mean LV dysfunction will be problematic. Therefore, we decided to come with a new definition, and that is cancer therapeutics-related cardiac dysfunction, and we use the acronym CTRCD. And we define it in a very specific way. We define it as a reduction of 10 absolute points of left ventricular ejection fraction to a value that is below the reference value of normal, which, as you know, from the second version of the chamber quantification guideline from Dr. Lang, is 53%. Then you can further subdivide the CTRCD into type 1 or type 2, and I'm going to explain in a second what the definition entails, and you can also define it in terms of the presence or absence of symptoms and with regards to reversibility. As I mentioned a few minutes ago, it is very important that you recognize two types of CTRCD. And more so than obsessing about the medication that could be responsible, I want you to think about this definition in a similar way to the one that we use for myocardial infarctions, where we divide them between STEMI and non-STEMI, trying to identify the situation that is trouble versus not trouble. So we want to make the same distinction between the two types of CTRCD. We want to emphasize the type 1, which is the one that you need to remember as trouble, because as you see in the slide set, it causes cellular death, and this damage is irreversible, it's permanent. You will be able to see these changes in the biopsy, and it's cumulative dose related. In contrast to that, Mike Ewer, several years ago, created the definition of what he calls a type 2, which is a situation where you are not going to have cellular death, you're going to have cellular dysfunction, you are not going to see changes in the biopsies, and it's not necessarily related to the dose that the patient has received, and it is reversible in most of the cases. So it is very important that you recognize that type 1 is bad news, type 2 in most of the cases can be reversible. But as you have seen also in clinical medicine, if we use the example of the ST versus non-ST elevation MI, you can have a patient that has a non-ST elevation MI, and if you allow the patient to be hypertensive and tachycardic, then this patient will behave as an ST elevation MI. So if we go back to the type 1 versus type 2, then you can imagine a situation where you take somebody that is older than 65 years old, that starts with a borderline ejection fraction, that has risk factors, coronary artery disease, hypertension, diabetes, hyperlipidemia, atrial fibrillation, chronic renal insufficiency, and you already know what is going to happen. This patient is not going to behave in an indolent way like a type 2. It's going to behave more like a type 1. So I just want to make sure that you guys do not get obsessed about the medication, but that you understand that what we are trying to do is we're trying to guide the clinician into making him aware that you have bad news versus a situation that may be potentially reversible. The second part of the document addresses probably the most important part of it, along with part 3, which I will cover in a few minutes, which is how is that we should do the echocardiographic evaluation of this cancer patient. When I was at Cleveland Clinic, I had the opportunity, along with my colleague Dinesh Tavendiranathan, who is right now at the University of Toronto, to do this valuable work where we ask ourselves a very simple question. And the question is, what is the inherent variability of 2D-based echocardiography when we follow patients sequentially? So what we did is we got patients that had absolutely a stable strain, and we figure out what was the variation of 2D versus 3D echocardiography. And as you can see over here from the results are actually humbling. We were able to conclude that when we use 2D echocardiography, we can only identify sequentially differences higher than 10 points of ejection fraction. It gets better with 3D ejection fraction, where we are able to recognize differences of 6 points. But you may imagine the implication that this has. I just mentioned to you that the definition of CTRCD will be adjudicated by a drop of 10 points. And if I tell you that 2D ejection fraction only allows you to recognize differences higher than 10 points, you get the message. The technique, 2D echocardiography, is not well suited to follow patients sequentially for the development of CTRCD. And if you want to do it effectively, you will need to use better technology like 3D echocardiography. When I started at Cleveland Clinic and when I was writing the imaging protocol there, we thought that if 3D echocardiography was good, and if I could use contrast, I would potentially be in a situation where I could have calculation of volumes and ejection fraction pretty similar to what MRI could furnish me. But as you can see, there is a small caveat, and that is the shadowing artifact that you are going to get in the ventricle out of the presence of the amount of contrast that you will have when you capture this pyramid of information. And I don't have to tell you, for you guys sonographers, but you can already know what is going on. I have beautiful endocardial border definition for the mid and for the apical segments, but I have no clue where the basal segments are located. Therefore, it is very possible that I'm going to be making a mistake in the calculation of the end diastolic and the end systolic volume, and that I'm going to be providing an erroneous calculation of ejection fraction. And that is the reason why, if we go back over here to this slide, you realize to the right of 3D with contrast, not only I didn't make things better, but I actually made things worse in terms of temporal variability of the ejection fraction. Therefore, the message is, if at all possible, I use 3D echocardiography, but I know what some of you are thinking. You are thinking, well, that technology is not available in my lab, is that going to be the end of the world? Well, we obviously recommend that you use the best possible technology that is available in your laboratory for the accurate calculation of ejection fraction. The third part of the document is really the part that was innovative, and this is the part where we recommend a strategy of early detection of toxicity. We present two options so that, again, the technology could be used in different labs all over the world, and then this technology is either the use of imaging with global longitudinal strain, which I'm about to explain to you, and the second strategy is the use of biomarkers using troponins. So you're going to see right now two pieces of literature that use two different strategies. The first one is going to use an arbitrary cutoff. The second one is going to look for a percentage reduction. So let me share with you the first piece of literature. So this is work that I had the pleasure of doing with Marielle Scherer-Crosby. By that time, she was at Mass General Hospital, also with collaboration from UPenn and from McGill. It was a beautiful experience. And what we did is we evaluated 81 patients. From these 81, 26 developed, and remember that by that time we had not published the expert consensus, so we were still talking about cardiotoxicity. 3 did it at the end of anthracyclines, and 23 did it while on trastuzumab. For the people that are not familiar with these medications, these are conventional medications for the treatment of breast cancer. What is important, as you realize over here with the statement at the bottom, is that only 6% of these patients were symptomatic. The rest of them were asymptomatic. So if you, in the cancer population, you're going to be looking for the patient that is huffing and puffing and that has swollen legs, you're going to be wasting your time because most of them are going to be asymptomatic, and hence, the importance of using advanced imaging to detect them. This slide shows you that although most of them did it within 3 months, you realize that if I had stopped looking at 3 months, then I would have lost the opportunity to detect these 9 patients that were identified asymptomatic, again, at 6, 9, and 12 months of follow-up while these patients were receiving the second medication, the trastuzumab. The results over here is that the only one that was predictive of subsequent cardiotoxicity, i.e., an abnormal global longitudinal strain during the course of the treatment, recognizing the patients that down the line were going to have a reduced ejection fraction, was the global longitudinal strain. And you have over here probably the most important table, that is the one that addresses the sensitivity and the specificity. So you have a sensitivity of 74%, a specificity of 73% if we use an arbitrary cutoff of -19 of global longitudinal strain. Underneath you have, as I mentioned before, using the biomarker strategy, the troponin I. If it's more than 30 picograms per ml, then the sensitivity is a bit lower, the specificity is about the same. But then if you remember your biostatistics, you see over here a negative predictive value of 91%. So what this means is that if the oncologist has sent a patient to me, and if I have used the GLS, and the GLS is more negative than -19, and if the ultrasensitive troponin I is lower than 30 picograms per ml, then I can tell the oncologist with a certainty of 91% that his patient is fine and that there is no evidence of subclinical LV dysfunction. Now, you may imagine that the problem of using these arbitrary cutoffs of -19 in this case is that it will be different depending upon the machine that I will use. And probably you guys have heard a lot about the vendor dependency of global longitudinal strain. So then when I was at Cleveland Clinic with Tom Marwick, we said, and what about if we use a different strategy? And if we use, and this is what we did in this study, what if we actually not look for an arbitrary cutoff, but we look for a percentage reduction, and by doing so, that will get us off the hook of what would be the normal value, because if it's a percentage reduction, then kind of the same principle will apply even if we use different machines. So this is what we did, and we kind of redid the experiment looking for the ability of global longitudinal strain to prognosticate a subsequent reduction in ejection fraction of more than 10 points of EF. And you have over here the conclusions. The conclusions is that the percentage reduction that work out the best in the receiving operator characteristics curve was 11% reduction. And you have over here kind of like a summary of the two strategies. So you have the arbitrary cutoff of -19, and you have the what we call there the CCF Brisbane, because it incorporated the data from Cleveland Clinic and from Brisbane, where we say that the mean percentage reduction is 11, but as you remember, when we are evaluating samples of population, we are not the owners of the truth, the whole truth, and nothing but the truth. But we have to give a confidence interval that will tell us that within this margin of error, we think that this is where the truth lies. And in this particular case, this 95% confidence interval goes to the left to 8, and I want you to remember these numbers because you're going to see them in a second, and to the right of 15%. So in the fourth part of the document, we acknowledge the role of the other modalities. So there are two modalities that you know should be discussed here. One is the MUGA, the nuclear medicine one, and the other one is MRI. So you know what is the problem with MUGA? The problem is radiation exposure. In the good old days, we didn't care that much about it. Right now, we do care a lot. And as you may imagine, it's pretty counterintuitive to give radiation to somebody that already has cancer. So that is the reason why right now we are not too excited about the use of this technique. Although if you are facing problems with the quality of images, and if you don't have MRI, then this may be a reasonable alternative. MRI, we all recognize in imaging that this is our gold standard for the calculation of LV volumes and EF. The problem, as you already know, is limited availability, but in the document, we actually endorse two situations for the use of CMR. One, a situation where you are concerned about the quality of the images, you cannot see things well, with echo, and that is not an infrequent occurrence. If you have imaged these patients, you remember, patients that have got mastectomies, you have remembered patients with breast expansors, you remember patients with brand new breast implants. All of these patients are very challenging to image, so it is very important to remember that this can be an alternative. And also in situations where out of the severity of the decision that you're about to make, i.e. suggesting stopping therapy, you want to be 100% sure that you are telling the oncologist the truth. So then in this last part, what I want to do is kind of put it all together, and we call it an integrated approach. And I want to do it with a patient. So this is a 47-year-old patient. And this is a patient that I had when I was at Cleveland Clinic, ER negative, PR negative, HER2, NEU positive, treated with docetaxel, carboplatinum, and trastuzumab. This is what the oncologists call the TCH therapy, followed by mastectomy. So then the document is very practical. So it tells you, all right, so you have a patient with cancer, you're about to start cancer therapeutics, which one of the two toxicities are you at risk of experiencing? So in this particular case, as you have already figured out, we are not giving any of the agents that is associated with the type 1 toxicity, which, as you remember, is the one that is bad news. We have an agent, trastuzumab, that is associated with type 2 toxicity. So then it tells you, all right, so you're going to initiate trastuzumab. So in this patient, you need to have a baseline evaluation of EF. 3D is the preferred modality, and if you're using 2D, consider contrast. If you have more than two segments on apical views, that will have inadequate endocardial border definition. And it tells you at the bottom of this square of that you need to have a global longitudinal strain or troponin I as a strategy for early detection. And then it tells you that if all of this is normal, then you need to follow the patient every 3 months. But if any of this is abnormal, then you need a cardiology consultation. So in this particular case, for the sake of the example, the initial ejection fraction was 65%. The follow-up at 3 months was 58%, so that is only a 7 absolute point reduction. The ejection fraction is 58, so I cannot adjudicate CTRCD. So what you need to do is you will need to pay attention to the strain. So the strain at baseline was minus 25.5. At follow-up, it was minus 19. So if you do your math, it will be 6.5 divided by 25.5. That is a 25% reduction. And if you come and if you follow the algorithm, it will tell you that, and you remember right now where the 8 and the 15 came from, the left and the right sides of the 95% confidence interval, it will tell you that you are in the presence of subclinical left ventricular dysfunction. Now, what do you do? Well, we don't know yet what to do, because if you take a look at the guidelines from ACC-AHA, it tells you that you can only move a patient from a stage A, which is everybody receiving chemotherapy, to a stage B, if you have previous MI, LV remodeling incorporating left ventricular hypertrophy and low EF, or asymptomatic valvular disease. So in this particular patient, we don't have any of these 3 instances. And then the question is, can I use this 15% reduction in GLS to adjudicate a stage B heart failure? We don't know the answer. Tom Marwick is doing a very elegant study called the SUCORE study. I imagine that some of you are participating. It's an international randomized study where the patients are randomized to the adjudication of a stage B, either the old way with a reduction in ejection fraction, or the new way with the percentage reduction in global longitudinal strain, and then the patients will be treated accordingly with modern heart failure therapy. What I can tell you is that looking in retrospective, looking backwards, and we did it when I was at Cleveland Clinic, we evaluated in this study what happens when the patients have received beta blockers, at the same time of their chemotherapy. And what we were able to conclude is that there was a reduction of 80% in the incidence of heart failure in the population that obviously received the beta blockers. So I hope, so in this particular case, let me share with you what happened. So this patient was given beta blockers. You see that the GLS improved from -19 to -22. It's not quite -25.5, but it's a GLS that is absolutely normal. So in this particular patient, we were able to achieve two outstanding outcomes, allow the patient to receive the full therapy, and second, doing so without any evidence of LV dysfunction. So with that, I come to the end of my presentation. I hope that I have summarized to you the most important points, from the consensus. First of all, the definition of CTRCD, drop of absolute 10 points of EF below 53%. Two types of CTRCD, type 1 and type 2. I have explained to you the importance of using 3D echocardiography for the surveillance of subclinical LV dysfunction and CTRCD. I have explained to you that there are two modalities that could be used, MUGA and MRI. And finally, I have walked you through the practical algorithms that we incorporated in the expert consensus, helping you sort out your patients on daily basis. And with that, I will pass the torch to my colleague, Pam Burgess, so that she can instruct you how to do this. Thank you.
Okay, thank you, Dr. Plana, for that really nice overview of cardiotoxicity. Next, we will look at this from a sonographer's view, and more specifically, look at the protocol that needs to be done with these patients. I have no disclosures. Okay, first of all, I wanted to talk a little bit about the learning curve with strain. We as sonographers know that most anything we do, there's a learning curve with ultrasound. So this article very nicely compared sonographers to medical students and everyone else, that didn't have echo experience. And what they found was that a sonographer needs about 50 studies in global longitudinal strain to provide consistency and reproducibility with their strain. So I know it's difficult at times. I can remember when I first started out doing strain, we really didn't have anyone else to go to here. We used our equipment vendors a lot to help us with it, but it's really important that you learn the processes of strain and that you feel comfortable with it to provide that consistency. Okay, so, like I said, perform approximately 50 cases with strain with assistance if possible. The things that you're really going to want to look at are kind of what we went over in part one of the webinar, which is, of course, image optimization. Strain is this is very important with strain to have an adequate image. Also, to really optimize your ECG and make sure that you have an optimal ECG when you're acquiring your strain images. Also, be real careful with your region of interest placement and the width of it, just to not go below the annulus of the mitral valve or not to be into the pericardium, which can cause altered results with your global longitudinal strain. And also just recognition of poor tracking. I know the systems are very automated now. The vendors have done very good jobs of making strain a lot easier for us as sonographers, but sometimes the tracking can not be adequate and can really alter your results too. So recognition of the pitfalls with strains, we talked about this before, heart rate alterations, arrhythmias are really important, and breath holding. And for this, these pitfalls here, I would just recommend that, especially when you're first starting out with strain, that you acquire your images and you perform the actual strain measurement while your patient's still there. So that actually, if you need to go back and reacquire images because maybe you had a PVC that you didn't notice before, or there was some variations with heart rate, whatever the case may be, that you could go back and still get the images while the patient's still there. So here's an example from Dr. Plana's paper of Cardio-Oncology Protocol, and the recommendation there was that we do a standard echo. Okay, so we acquire all our things that we normally do, per ASC guidelines and IAC guidelines for a protocol. And in addition to that, what we do is we add our strain. And you can acquire the strain images a couple different ways. One is we can acquire all three images within one cardiac cycle, or we can go individually and do each of the three apical views. And with that, we would need to be very careful with any heart rate variation there. Also from that, we would need to ensure that our frame rates are adequate, things like that, our image depth. Also, we would need to quantify the global longitudinal strain, looking at the segmental curves and also with the bullseye, evaluating for any ectopy or breathing translation, and also do, as Dr. Plana said, a 3D EF if you have 3D capabilities on your equipment. If not, of course, you can do the biplane method as well. So reporting to, there's a list of things that should be reported there with these patients, especially their vital signs and other things that are listed here. So, okay, so here's an example of a patient that had strain performed. And you can see that we've performed the strain in each of the three apical views, an apical long, apical 4-chamber, and apical 2-chamber. And we are very careful here not to go down into the left ventricular outflow tract or down below the mitral annulus. We assured that we had good tracking, that the region of interest was placed correctly and not too wide, and that we had a good EKG as well, and that our curves looked good there. So that's something that we would want to look at each view in detail, and then also look at our bullseye view. And here you can see where we have our global longitudinal strain average displayed here, which is a very normal one. Okay, so also we would want to do a calculation of left ventricular ejection fraction, and probably most of you guys are doing the Simpson's biplane trace, where we take a lot of pains and care to optimize our image. We kind of decrease the depth here so we can really zoom up on the left ventricle and get good endocardial definition so we can begin our trace at the mitral valve annulus and trace around to the opposite annulus. Of course, we would do this in diastolic and systolic frames from an apical 4-chamber view and also from an apical 2-chamber view. In addition to that, if you have 3D capabilities, you could also do a 3D ejection fraction in volume there as well. This is a little more difficult for a sonographer to do from the 3D perspective. And keep in mind, too, that contrast really doesn't work with 3D. So there are some patients that we would need to add contrast with. And, of course, as Dr. Plana said, if there's 2 or more missing continuous LV segments, we would want to add contrast. In our lab, we have a very low tolerance for moving ahead with contrast on these patients. We feel that it's more reproducible, the trace, and more consistent for us. So, again, you can just do your Simpson's biplane in your apical 4 and apical 2-chamber and just trace right around the border there of the contrast. So remember that contrast and strain don't really work together too well. So if you're going to attempt strain, in our lab we always administer the contrast after we've performed the strain, because that can affect your results with the strain as well. So, Okay, so, LV diastolic function is something that we do within our protocol normally, but I just kind of wanted to highlight this a little extra because it's important to grade the diastolic function here. Sometimes we'll see diastolic changes prior to systolic changes on these patients. So the other thing we would want to look at is our E to E prime ratio. And just to kind of caution you with this, to remember that these velocities change as a result of loading conditions. And loading conditions change based on volume changes. And if we think about our chemotherapy patients, they have a lot of side effects. And, the side effects we see is these people have nausea, they have vomiting, they have diarrhea, things that really changes the volume. So we have to be careful when we look at that. And you may even want to go back and look at your left ventricular volume that you just traced and compare it to the last study to see what changes you have there. Okay, next, another thing is if sometimes when we have a reduction in left ventricular function, we'll also have a reduction in right ventricular function as well. So we'd want to assess the chamber size, and we just do a quick measurement at the RV basal diameter. We also look at the right atrial size, just doing a quick right atrial area trace. We do TAPSE on these patients, much like we do with our normal heart failure patients. And we also do a pulsed DTI on these patients, looking at the peak systolic velocity at the tricuspid annulus. And we also do an RV fractional area shortening on these patients as well, so just tracing the RV in diastole and systole. So here's an example of a patient that we did. And you can see on the left of the screen here, we performed TAPSE on this patient, being very careful to go over and do more of a focused RV view so we could line up and become perpendicular to the RV free wall annulus there. Again, on the right side of the screen, we've done pulse Doppler, looking at the peak systolic velocity on the RV free wall there at the tricuspid annulus. Okay, so some of these people come to us and they have totally normal hearts. Some of them come to us and they have had some valvular heart disease in the past. Some of them may develop valvular heart disease as they go through therapy, which what I'm referring to there is endocarditis. Some of these patients will have remodeling of their left ventricle as their ventricle dilates, and that can cause mitral regurgitation. So if our patient presents with mitral regurgitation initially or develops it throughout the course of treatment, we would want to assess the amount of regurgitation. Also with tricuspid regurgitation that can occur with RV dysfunction or pulmonary hypertension, we would want to assess that as well. And just remember, if there's any baseline changes, this may require more frequent echocardiograms for those patients. Pericardial disease is something else that we see kind of frequently with these patients. They develop effusions, so we should also quantify the effusion and evaluate that patient for any tamponade. General pericardial evaluation should also be performed for any tumors or masses or constrictive pericarditis if the patient's had any radiation. Okay, next I want to quickly show you a cardiotoxicity case. This is a 56-year-old female that presented to us. She had a history of metastatic breast cancer. The patient was given Herceptin. She had no previous cardiac history or risk factors. On her initial echo, it revealed that she had a normal ejection fraction, a low normal ejection fraction of approximately 50 to 55%, and her global longitudinal strain average was negative 17.6%. Okay, so this study was probably about 3 to 4 months out, and when we scanned her, we traced out a Simpson's biplane on her and noted that her EF was approximately 35 to 40%, and we had a significant drop in her global longitudinal strain average. Remember, it was 17.6 at her baseline study, and now we're down to 13.1. So we had approximately a 25% drop in her global longitudinal strain average from her baseline study. Her next echo, which was performed a couple weeks ago, we saw this patient in the echo lab and performed a pretty good trace on her from and did a Simpson's biplane and noted that her EF had recovered to about 45 to 50% here. Let me get that to play. So you can see her triplane imaging here, and this is the way that we gathered and measured her strain. And you can also see there's still some reduction in her global longitudinal strain. It has rebounded slightly, but still very abnormal there. And you can just see the flattening of the curves and everything on this particular lady, though. So sonographer role in cardiotoxicity, I think the biggest role is to get past that sonographer learning curve with the strain and produce reproducible strain imaging. I would also encourage the sonographers to review the previous echoes and just see what the patient looked like previously as far as their ejection fraction and their global longitudinal strain. And remember, these patients may have no symptoms, and their EFs may be totally normal, and their strain may be abnormal. So we have to watch for that. Make sure that your results make sense. We've had a couple strain cases where they made no sense. They were grossly abnormal with, what appeared to be a normal EF. So just make sure that you check your region of interest placement, you check your EKGs, anything that can affect this. And also highly encourage you to utilize contrast on your difficult patients. Strain may not be available per the difficulty of the patient. So we know that, as Dr. Plana said, these patients have had surgery, and even with the best of equipment, we're not going to be able to get strain on everyone. So I would encourage you to have a very low tolerance to move ahead and utilize contrast on these patients so that you can better trace an EF on them and more reliably and consistently. Okay, and I think that finishes my presentation.
Okay, thanks, Pam. And at this time, we'll begin the Q&A session. From IAC Echo, I'd like to introduce Sue Jensen and Ann Groves. They're clinical specialists, and they will be assisting with the Q&A session today. Sue, would you like to start us off?
Yeah, sure, Kelly. I think we're going to go back to one more question, Pam, just to make this clear. There's a couple of questions about that you don't want them to use contrast and strain imaging, correct? It's only if, using it if you can't get good image.
Correct.
That was one of the questions. And also, if you have a technical difficult study like mastectomy or status post-breast reconstruction, how can you improve strain accuracy?
I think it really is all based on your 2D image quality, and we really have to optimize these images and use our sonography skills to, get the optimal image that we can on these patients, and sometimes it's rolling the patients back and forth, utilizing dropouts, and just, working with our equipment to bring in the endocardium. And it's very difficult. As Dr. Plana said, these are probably some of the hardest patients we're going to be scanning. They've had surgery, they've got expanders in, whatever, and they're at times extremely difficult to image.
I would like to add something, and I think that it is very important that if we feel uncomfortable with the quality of the images, we do not want to go and process and report the strain. When I was at Cleveland Clinic, Tom Marwick, who was my boss there, emphasized over and over and over as we were developing all of this technology and creating the expert consensus that we need to remember that these patients already have a big problem. They are facing cancer and they're getting treatment for it. and we do not want to create a problem that doesn't exist. And we don't want to do it, if this would be just the result of us trying to use images that are of suboptimal quality.
Okay, Rajni asks, can you perform strain while a patient is on a dobutamine drip?
So the answer is yes, you can. I think that we talked a little bit about that in the previous webinar. The issue is the issue of heart rate. So if your heart rate is with a dobutamine injection around 100, 110, it's still doable. But if you have dialed up, your dobutamine dose, to the later stages, and you are at 140, 160, it's not going to work. I mean, a good rule of thumb for strain imaging is that you would like the heart rate and the frame rate to be the same. And as right now with the current technology, we can go to frame rates, up to 100 or so, but not higher than that.
Okay, Pam, I'm having a lot of questions from sonographers. So first of all, they want to know, do you have the same sonographer do all your studies to decrease variability? And then do you normally perform a limited echo when serial echoes for cancer patients after a full initial echo is performed?
As far as the same sonographers performing them, no. We have worked very diligently with our sonographers to have them all perform strain. We don't initially, and if we have new sonographers, we let them season a little bit, and then we start working with them on strain, and just to make sure that they're, optimizing as best as possible. We may let them do the initial part of the exam, and then we'll have a sonographer that's a little more seasoned with strain come in and help them obtain the strain images and perform the actual measurement. What was the second part of that, Sue?
They want to know if you do limited or full echoes when you do the serial echoes after chemo.
Yeah, we kind of get a mixed bag here. I would say for the most part, we do a full echo on every patient. There are some physicians in our cancer center that will order limited for the serial exam. So.
Mm-hmm.
And if I may add, I really like the way that you answer, Pam, because you need to be open-minded. These patients could have had progression of disease. You could see evidence of new pericardial effusions or new evidence of metastatic disease, or evidence of Lippmann-Sack endocarditis, or Marantic, So you have to be careful, that you really evaluate the patient thoroughly.
Yeah. So even if we have a patient that's ordered for a limited and we see something that we need to look at further, we will move ahead and do that with the limited order.
Okay, Susan asks, if a patient's baseline strain is abnormal and they are getting ready to start chemo, do you still use a change of 15% to identify toxicity and LV dysfunction?
Well, I mean, if your strain is already abnormal, I think what is important is what is your baseline ejection fraction? I mean, are you already adjudicating, evidence of LV dysfunction? Because at the end of the day, all of this strategy, the whole goal for it is to identify patients that could benefit from heart failure therapy. So if you are already starting with a strain that is abnormal, then you need to ask yourself, is the ejection fraction, lower than 53% or not? And if it is, then you can start therapy. And then what you need to look for is what is going to happen, with the progression of a strain as the patient receives therapy. Obviously, when you start chemotherapeutic agents in the presence of abnormal LV dysfunction, either, adjudicated by global longitudinal strain or by ejection fraction, that this is a patient that is already at risk. risk.
Okay, we have two questions that are rather similar, so I thought I'll ask them together. After you get a change in GLS, do you have to repeat it to confirm it? And if yes, how long after the prior assessment? And also, how often do you do a follow-up echo after chemotherapy if the numbers are reassuring?
So the expert consensus, and again, the same applies to ejection fraction, mandates that you repeat the exam, within 3 weeks, because you want to be 100% sure that if you are going to be blowing the whistle, you have actually two different sets of images in two different moments of time where you are seeing exactly the same thing for the reasons that I explained before. Then how often do you repeat it? Then you will need to follow the algorithms. The guidelines are different, for anthracyclines and for trastuzumab. For anthracyclines, we mandate to repeat every increment of 40 milligrams per meter square of doxorubicin or equivalent dose that you get. And then for trastuzumab, we recommend to evaluate every 3 months. And the way that we do it is we do it the night prior to the administration of the chemo.
So we also ask our sonographers here if they do a strain and it's abnormal that they repeat it again while the patient is still here, and just to kind of confirm that the results actually are abnormal.
Okay, Shelley asks, why do you calculate the right atrial area instead of the right atrial volume?
That's just in our regular protocol that we do a right atrial area, and it was also in Dr. Plana's article as well, so I would kind of defer to him as to why it was an area and not a volume.
Sure, because, if you take a look at, and again, you need to remember that at that time, we were operating on the previous version of the chamber quantification guideline because the new one came about 4 months after our consensus. So at that moment in time, the chamber quantification guideline was mandating the calculation of right atrial area and not volume.
Okay, if a thrombus is found in the apex of a cancer patient, will that throw off strain values?
So no, it's not gonna create interference with the calculation of a strain because the thrombus is attached to that apical segment, but is not one that we are gonna incorporate in the region of interest. In the majority of the cases, what I will anticipate to see is an area of very poor strain, identifying a wall motion abnormality, probably a segment that is akinetic.
Okay, Michelle asks, if the patient's EF went from 50 to 55 down to 35 or 40, and you know the chemo is affecting the patient, why do the strain?
Well, that is an excellent question. You don't have to do the strain. If you take a look at the algorithm that I show, once you have documented a 10-point drop of ejection fraction below the ejection fraction of 53%, you are done. You have adjudicated cancer therapeutic-related cardiac dysfunction, and you need to start the patient on heart failure therapy. But I think her question really opens up a bigger discussion, and that is the area of when is a strain helpful in clinical medicine. And although there is some data as to the prognostic value in patients that have low ejection fraction, I find it particularly useful in the patients that have normal or near normal ejection fraction in the identification of subclinical LV dysfunction.
Okay. What is included in the physician's report when reporting out on strain that was obtained during the study? And this particular question, they in strain in their practice, but some of the physicians are not reporting out the measurements.
So I think that this represents, how things evolve in clinical medicine. Initially it's research, Then there is a few clinicians, that are the early adopters. And then right now you have an expert consensus that recommends to use it. You have the guideline from the American Society of Clinical Oncology that also endorses the use of a strain. So I think that we have made the transition where people recognize the role of GLS in the early detection. And for the labs where it's not being reported, I think that it's probably a reflection of lack of familiarity of the practitioners with the technique. So, but this happens with almost every technique. The way in which it's embraced doesn't happen overnight. All of these things take time.
Okay, Amy asks, do you measure the GPLS several times with different sets of images and you average that, or is it just one measurement?
In our lab, we will do it several times just to make sure that we're reproducible and our results are accurate. So we may even go back and obtain more images if we notice something's not quite the way we feel it should be. So like I said before, there's a learning curve, and it takes a while to notice everything. So you may be missing a segment. You may have an area that is not tracking well, and you just have to go back and, at times we initially attempt to do the triplane imaging. And sometimes if the patient's a little difficult or we can't quite pull in one of the views, we'll go back and we'll acquire all the views separately. So we may initially start out using the triplane and do our calculation of strain from that approach, and then find that we have to drop back and go view to view with it. So we do it a couple different ways, just based on the patient, technically difficult patients. Of course, we're working a lot more with the images and probably acquiring a lot more of those images for the strain.
There's a question, do you order troponins with each echo?
So the answer is no. We don't do it over here. Really the reason why we incorporated biomarkers, as I mentioned before, is so that we can make, the expert consensus applicable and useful really everywhere in the world. I think that in almost every hospital that I have visited, in several continents, they at least have troponins available. So we just wanted to emphasize the importance of early detection. Now, if you use both, I have already explained what happens with the negative predictive value. But to be honest with you, in the institutions where we have applied it, we use imaging only.
Okay, Diana asks, do strain evaluations need to be done before you start chemo, or can you get a baseline after they have already had a treatment or two?
So the answer is before. You don't want to incorporate any element of confusion. And as I have mentioned, there are patients that can react to chemotherapy adversely even with the first dose. So obviously you want to get a baseline as to how the patient looked like before receiving any potentially cardiotoxic therapies.
And what if a patient's already having LV dysfunction before starting toxic drugs?
So like I mentioned before, then you can use global longitudinal strain as a sensitive measurement to really track the progress. So let me give you an example. For patients on trastuzumab, right now we tolerate initiating trastuzumab when the LV ejection fraction is 40 to 50, but you know that you're playing with fire a little bit, so that you want to use a strain as a very sensitive indicator to follow small changes and to react accordingly.
Okay. Thanks again, everyone, and a very special thank you to our guest presenters today. Please feel free to contact IAC Echo with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. At the conclusion of the live session, the survey will be available from the IAC Pro Libraries website for 3 business days. Go to www.prolibraries.com/IAC and log in. In the upper left, click on My Webinars. Look for the title of this session, Building Blocks of Strain Imaging, Part 2. Beneath this title, you will see the link Take Evaluation. Click this link to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you all for joining us today and appreciate your participation.